Okay, I think we should probably get started. I'd like to welcome everyone. It's a beautiful summer's day here on the Midwest of the United States. I look forward to a wonderful session today. So wherever you are across the world, welcome to this iteration, the summer iteration of kind of the neonatal hemodynamics webinar series. We've got a very exciting talk today, a topic we actually have not spoken about very much on the hemodynamic world press, and we have an exceptional speaker and panelists that are available to us. So without further ado, I will hand this over to my co-host, Dr. Rachael Hyland, who's an assistant professor of pediatrics here at the University of Iowa and another rising star in the field of neonatal hemodynamics. Rachael, the floor is yours.
Thank you so much, Patrick. And I echo Patrick. I'm really excited to hear Dr. Altit's excellent talk. So to give you a little bit of background, you really don't need an introduction at this point, Gabriel, but Dr. Altit is an associate professor in the Department of Peds and a staff neonatologist at the McGill University Health Center. He's a clinician scientist, founder of the NeoCardio Lab, where his research focuses on neonatal cardiovascular physiology, cardiac POCUS, and advanced imaging. He also directs McGill's Royal College accredited fellowship program in neonatal hemodynamics, co-chairs the NHRC, TNE, and PA Foundations curriculum, and serves on both the Fetus and Newborn Committee of the Canadian Pediatric Society and the PAS Neonatal Hemodynamics Club Advisory Board. So very accomplished, and we're really looking forward, Dr. Altit, to hearing your talk. Take it away.
Thank you, Dr. Hyland. Thank you, Dr. McNamara, for having me. I will share my slide. So it's really an honor and privilege to be able to present to the NHRC PHC webinar today. Thank you for having me as a guest speaker. It's quite an honor and really a pleasure, and I'm really looking forward to discuss with the panelists and moderators on this topic, which is quite a interesting hemodynamic topic. So I will be giving about 30 minutes of discussion on the topic, and then we'll go on with the discussion with the panelists and moderators. So we'll try to tackle some of the risk factors, some of the hemodynamics phenotypes, and how to prevent and treat pulmonary hemorrhage in our newborns. These are my disclosures. I do want to mention that some of the graphics are coming from a review that I co-authored with Dr. Satyan. And obviously this current presentation is my own interpretation of the literature and based a bit on my experience. But I'm going to try to bring some of the science that's out there. As you know, many of the medications that we use in the context of pulmonary hemorrhage have not been tested in randomized controlled trial. And Mallinckrodt did support my NeoCardio Lab platform through an unrestricted educational grant. So I did put together a little QR code. I have a tendency to speak too fast, so I decided to post my slides so that everyone can go back and look into them if they're interested. There's also a copy of the review, which is open source if you scan the QR. But really my objective today is to, at the end of the session, I hope that all the participants will be able to outline some of our understanding of the pathophysiology from a hemodynamics and cardiorespiratory standpoint, and some of the key risk factors associated with pulmonary hemorrhages. We'll talk about some of the strategies for early identification and prevention, and we'll discuss a bit of the approaches to minimize the risk and manage pulmonary hemorrhage in some of these patients. So I'll start with two brief cases to outline some of the phenotypes we see in some of our patients with pulmonary hemorrhages, thankfully being a rare entity, but unfortunately being often a catastrophic entity. So the first case is a baby born at 26 weeks who was covered with only one betamethasone and had to be rushed for a C-section in the context of severe maternal health. This patient was growth restricted, did require an intubation and eventually received surfactant with good response, but at 36 hours had a rapid decompensation with significant blood pouring in the endotracheal tube. This patient was placed on high-frequency oscillation, and MAP was progressively increased to very high levels in the 17 to try to mitigate some of the bleeding. And due to hypoxia, the patient even received endotracheal epinephrine and blood products, and eventually surfactant was re-administered once there was less trace of blood in the ET tube. So here I've put the x-ray for this particular patient. You can see that initially this patient was made a bit too overinflated and eventually got a catastrophic pulmonary hemorrhage with disappearance of very kind of diffuse whiteout of the lungs. So because the patient in the post-hemorrhage phase developed pre and post differential saturations, there's a TNE that was requested for both understanding cardiac function and phenotypic characterization, and also because this patient was very hypoxic at that point. So these are parasternal view. We can see here the left ventricle, its contraction looks to be preserved and it's confirmed via short contraction, which is within normal limit. But we can see that when we go posteriorly, there's the RV inflow view with some degree of TR, which is moderate, and we'll see the RV-RE gradient very soon. This is an LA on aorta ratio, which outlines that the LA at this point is not yet dilated, which would be quite early at a few hours of age to have a dilated left atrium. This is a short axis where we can see that the LV contraction, at least subjectively, looks okay. But what is of interest is that there's some degree of septal flattening, and the eccentricity index was above 1.3 in this case. We can here have RV-RE gradient via TR jet that outlines that the RV systolic pressure are in isosystemic range because the BP at that time was 59/44 in the postductal aorta. Here we have a ductal cut view. I think you can appreciate, and I've put it as a still frame, that the PDA is quite big compared to the RP and LPA. And we can see here via color as well as pulse wave Doppler that at that point in time, the PDA is completely right to left. From a apical view, we can see that the RV function was preserved. We get a TAPC of 7 millimeter. Part of this reason could be because there's a bit of TR, which will, it's always easy to pump against a low pressure right atrium. But also, we know that in the face of a large PDA, you get pressure equalization on the two sides of the ductus. And so the RV may be offloaded in terms of afterload and is able to maintain systolic function. But this is at the cost of very low QP to QS with less pulmonary blood flow because there's a lot of right to left shunting at the PDA level. But there's also a limited amount of right ventricular output, probably because part of the right ventricular output is going backward into the right atrium. Here we see the interatrial shunt in this particular patient, where you see that here you have a completely right to left shunt. I want to, maybe for you to pay attention that the ASD had a very small diameter at that point. So that will be some of the discussion we'll have later in some of these patients is the offloading of the left atrium. But in this particular case, post-pulmonary hemorrhage, we had a right to left shunt at the interatrial level, and you can see it also by pulse wave Doppler at the level of the PFO. So this is a busy slide. I'm going to try to work you through. It's just the physiology after pulmonary hemorrhage in this particular patient. We know these babies may have, profound hypoxia, which can lead to reactive pulmonary vascular resistances increase, plus the acidosis, which can have a similar effect. You can have a reactive pulmonary vasoconstriction to tamponade the bleed. Of course, this patient was exposed to endotracheal ET tube, which can also participate to that. Excessive mean airway pressure can be definitely a contributor to the increased RV afterload, and by squishing these, capillaries and arterioles within the alveoli may also participate in the high PVR state. And on top of that, we know these patients had underwent a significant loss in preload of the left atrium because there's ongoing bleed at the level of the pulmonary parenchyma, so your venous return might be diminished, which means that if you have diminished left atrial preload relative to the RA preload, this may also participate to that right to left shunting, especially when there's significant TR. So in this particular patient, we had a preductal SAT of 81%, postductal SAT of 73. We know that there's probably a degree of EQ mismatch with all the ongoing bleed in the pulmonary parenchyma. So we don't expect these pulmonary venous SAT to be completely normal. I've put here arbitrarily 85%. Typically, we get about a 30% of systemic venous difference in terms of oxygen extraction. So if you have about 40% coming back to right atrium, mixing in your LA, you go down to 81. You don't have any post-tricuspid shunt in this patient, so you end up with a preductal SAT of 81. And because you have a right to left shunt at the PDA, you end up with these pre and post saturation differences. In this particular case, we know there's diminished pulmonary blood flow because the RVO was decreased, but we also see that there's a right to left shunt at the PDA level, most likely related to very high PVR relative to SVR, And because we had adequate systemic blood pressure at the time of the echo, it was felt that this patient had a phenotype of acute pulmonary hypertension for all of these reasons. So this patient actually, although this is outside of our CT recommendation, we decided to treat the physiology of this particular baby at that point, and we initiated INO with immediate response. So you can see here the pre and posts actually normalizing, the amount of oxygen improving, and the mean pressure was progressively decreased as part of our recommendation and eventually brought back to 12. pH, PCO2, lactate completely normalized over the course of the next 24 hours. And on next TNE that was done the next day, you can see now that your PDA has more of a restrictive pattern with higher diastolic velocities and a bit of this sawtooth appearance and a higher gradient at a peak of systole. We are completely left to right. Pulmonary venous flow in terms of the velocities looks adequate. You have a round septum. Your RV and LV function looks within normal limit. So at that point, INO was completely weaned. The second phenotype I do want to present, which is probably the most common one, is these patients with a significant shunt at the PDA level that is left to right, overwhelming the pulmonary vasculature. So this is a 27-weeker with no beta-metazone, presenting with preterm labor, transition to CPAP, requiring surfactant in the first 16 hours of life, and sadly developed a right pneumothorax. And at 12 hours, had a similar catastrophic pulmonary hemorrhages with a baby that was profoundly hypoxic. This baby was managed similarly and did get surfactant re-administered at some point when the blood decreased in the ET tube, but post-second surfactant, there was blood again, and the echo was requested. At that point, the patient went on jet ventilator with a MAP of 12. Jet is often our primary intention for these patients with air leaks. So this is a bit of another phenotype post-pulmonary hemorrhage. Here we see that this patient has, a significant duct. The measure was about the measure of the LPA, completely left to right, pulsatile and unrestricted in pattern. And you can see here that you have relatively good LA preload, LV function, with all the metrics of LVO that was quite elevated actually for this particular patient. Just briefly, because I cannot go into full TNE, but you can see here that the interatrial shunt was quite small and looked quite, of high velocity because you have a Nyquist that's relatively high and you can still see the jet, indicating that the LA is likely kind of overfilled. And I think you can appreciate it from this view relative to the RA. So here you have the pulmonary venous flow that you can see clearly at a higher Nyquist, indicating that there's relatively high velocity coming back in the pulmonary venous circulation. And so when we did do a lung ultrasound in this patient, you can see that there's a complete whiteout in the full lobes, even with areas of consolidation and a subpleural kind of atelectasis and all these coalescent B lines, which tells you that there might be a process of edema or consolidation. So this patient was treated actually with Tylenol. The PDA became restrictive on the next TNE, and the pulmonary hemorrhage actually completely subsided in this patient. Now, the problem with this disease is that when you have catastrophic pulmonary hemorrhages, it's often associated with severe brain bleeds and severe IVH. And the mechanisms, although not completely elucidated, is thought to be multifactorial. Part of it may be related to the response in terms of the treatment that we do for these patients. So that's one key element I want everyone to remember is probably going too excessively on your mean airway pressure may not be necessary in many of these patients. And that's why TNE can help you gauge how much of the contributor may be some of these hemodynamics profile for the response to treatment in these patients. Because if you increase too much the MAP, you will increase your intrathoracic pressure, you will increase your venous pressure in your SVC, and you may increase cerebral venous draining pressure, which in the context of fragile cerebral vasculature can also lead to burst of capillaries. We also know that many of these patients, if they had ongoing steal effect from their cerebral vasculature, it may have put the cerebral vasculature at risk. And of course, when you have very drastic hemodynamic shifts, such as giving catecholamines, administrating ET tube epinephrine, flooding this patient with packed red blood cells or platelets, that may also put a lot of strain on this very fragile cerebral vasculature. So it's very important in these contexts to be quite careful about how to manage these patients and avoid being too drastic and too brutal to prevent some of these consequences. So this is the review. And for this presentation in the next 20 minutes, I will try to outline some of the key messages that we work as a team to put together in this review. So the timing of pulmonary hemorrhages is frequently around the first 48 to 96 hours, and it depends on each cohort that you will see, but it's been reported up to 2 weeks of life, especially in the context of ongoing sepsis or NEC, which may occur a bit later. And it's typically related to the fact that these patients have very immature pulmonary vasculature, and within an acute drop in pulmonary vascular resistance, these patients have pulmonary vasculature which is ill-equipped to accommodate this rapid increase in pulmonary blood flow. And so if on top you get other hindrance, such as, for example, a stiff left ventricle, which is non-compliant, or even a small interatrial shunt, which may not be able to decompress the left atrium, you may get a component of this pulmonary venous phenotype where you get backup of blood flow within this venous compartment, eventually within the capillaries, and eventually you can have a burst of these capillaries. And of course, the PDA that is increasing the pulmonary blood flow more acutely is thought to have some role into this combination of factors. Now, clinically, we know how these patients can become quite ill. They often present with acute hypoxemia and respiratory failure. But there are some confounders because, the degree of severity of these patients in terms of their presentation can be related also to some of these patients having birth asphyxia, hypothermia, as well as all of these other factors of early poor transition of prematurity, such as RDS, sepsis, pneumothorax. But there's probably other things that we do in the context of the management of these patients that may entertain a pulmonary hemorrhage or put you at risk of pulmonary hemorrhage. We'll try to deconstruct some of them, but to name kind of the key ones, we can think about things that will more acutely drop the PVR excessively. So if you're overventilating your patient and your PCO2 drops too quickly, you may further decrease your PVR. If your patient is being exposed to INO while there's no signs of pulmonary hypertension and you have complete left to right PDA, unless you have a functional pulmonary stenosis, it should not be something that you entertain because that's been shown to increase bad outcomes in some of our preemies and may relax more the pulmonary vasculature in a patient that has already too much pulmonary blood flow. And of course, if you have a post-capillary phenotype with severe LV dysfunction, mitral valve disease, or signs of left atrial or pulmonary venous disease, you may end up with post-capillary congestion, which may also lead to pulmonary hemorrhage in some of these patients, at least theoretically. And then finally, some of the vasopressors or cardiovascular medication that we may start may have differential effect on the systemic and pulmonary vasculature. And if you increase too much your SVR relative to your PVR, you may increase the shunt through the duct in a left to right direction in terms of the volume and overwhelm even more your pulmonary vasculature. So another key message is that if your baby is showcasing sign of, low numbers of blood pressure, but otherwise as well, and your assessment comprehensive at bedside showcases that your baby is perfusing adequately and that you're doing all your due diligence at understanding what's happening at the systolic, diastolic knee, plus your TNE and echo picture, avoid introducing some of these cardiovascular medication for only treating numbers because you may also lead to more issue down the road. So other thing is that we know surfactant improves RDS, but it does have an impact on in PVR. So we'll discuss a bit more that. And we know that pulmonary hemorrhage remains a major cause of mortality. That's a beautiful graphic that kind of summarizes a bit of what I said. One of the things that's clearly delineated from the cohorts is that IUGR and or SGA, as well as male sex, seems to be a huge risk factor for this condition, especially for the more catastrophic ones. How to define it remains a bit of a controversial topic. There are different studies that use different definition, and so that's why you sometimes see some variability in incidence and outcomes based on that. Of course, like a trace of blood versus catastrophic blood outpouring in your ET tube will be quite different in terms of a pulmonary hemorrhage. But to quote Justice Potter Stewart, he was talking about nude art versus pornography. He was saying, I know it when I see it. So I think, these patients that have frank blood in your ET tube requiring an emergency intubation who are hypoxemic are kind of this dreadful condition that we're talking about today. So for diagnosis, well, again, sudden deterioration, pink, frothy secretion, or frank blood in the ET tube. Sometimes it might be swallowed blood, so you have to be careful. If you have a lot of gastric tube blood coming back, it could be from an origin in the lungs, so be aware of that. These patients can become quite hemodynamically unstable because they lose a lot of preload. Their mean pressure that is being cranked up can cause a lot of issue to the right heart and to pulmonary venous return. And you may have secondary hypoxia with ischemia and decreased coronary perfusion. And if your right atrial pressure starts rising, you get transcoronary issue in terms of perfusion because your coronary sinus drains to your right atrium in these patients if you have a normal cardiac configuration. So on X-ray, we often see these diffuse infiltrates with alveolar flooding. And on labs, you can see drops in hemoglobin or hematocrit eventually. Often they get some coagulopathy, acidosis, and disseminated intravascular coagulation. And for those units who have started to integrate lung ultrasound, well, you would start seeing some increased echogenicity, increased consolidation, coalescent V lines, and sometimes what we call a shred sign, which looks like a paper that you smushed together. So this is an X-ray of a kid who might be a bit too overinflated, and then post-pulmonary hemorrhage, you see that there's a full whiteout. This ET tube might also be a bit too low. So you always have to wonder, is there a component of airway disease in some of these patients that could be the source of the bleed? And so that could be also something that's part of your differential when you're assessing some of these patients. It is thankfully very rare. Depending on which cohort you're going to see, it goes up to 23%, but it depends on definition and the context. Most North American and European cohorts have provided a rate of 6 to 10%. In our unit, we recently published our population of patients, and in less than 26 weeks, we had a rate of 7%, and above 26 weeks, a rate of 6%. So it thankfully remains quite rare. But the problem with that is the mortality is up to 60%. And of course, there's a lot of factors that influence its incidence. So surfactant use practices, ventilation practices, whether or not it's a population with a lot of outborns with less preparation, less antenatal steroids, less prenatal care are associated with more of these disturbed transition. We know that admission temperature and ventilation strategies could also impact CO2 levels, which will acutely drop or maintain PVR in a more prolonged fashion of time. And male sex was already mentioned. So recently, Australia, in the area of New South Wales and the Australian Capital Territory reported their population of patients with prematurely less than 29 weeks, as well as the incidence of pulmonary hemorrhage, which was around 6%, a bit similar to our cohort. You could see that factors associated with a strong risk of pulmonary hemorrhage is, again, being born small for gestational age, 5 versus 11%. Being less than 26 weeks, so they had a bit of a bigger number, 10% versus 4%. And PDA actually was treated more often in these patients with pulmonary hemorrhage, but I think this is a confounder by indication. I think these patients got a pulmonary hemorrhage, so of course they're more at risk of having some kind of exposure to PDA treatment. And then finally, they again reported a very strong association with mortality and severe IVH. I've put here the incidence by year, so all in blue is the entire population, and you can see that this entity, which thankfully remains rare, is something that really kind of staggers in time and doesn't move much. I've highlighted all the factors that I mentioned previously associated with pulmonary hemorrhage. I do want to mention that, low platelet, intubation and delivery, receiving surfactant, having steroids exposure and being outborn are kind of all interlinked together, especially with gestational age. So a lot of these factors come as a kind of package, basically, of being more high risk. And it's just to keep that in mind when you're assessing some of these patients. Recently in the US, there's been this great report looking at some of these factors influencing mortality, and pulmonary hemorrhage remains one with the highest fruit rate in terms of risk of mortality, which really is well beyond some of these other elements like asphyxia or RDS. And so it's just to tell you that although rare, once it occurs, it's quite a difficult condition to manage. The great work by Dr. Hébert from Quebec City is one of our panelists today. We'll have the chance to discuss more of that. I just wanted to point out from this poster that was at PAS 2 years ago that, again, PDA was part of the very common factors in the cases compared to controls, in this case control study. What they found, though, was that the PFO size was a bit bigger in the cases than the controls. And, one of my hypotheses is, could it be it's because of the being a bit more stretched? So if you have these LA that are receiving much more pulmonary blood flow, sometimes the L pressure starts rising and you get like a stretched PFO because of this. You can see that these patients were more often on surfactant. They were much more often IUGR, growth restricted, more often on mechanical ventilation, and obviously more association with mortality and new onset IVH. So the ventilation mode could be associated with the fact that these patients are just more ill, but it could also be a trigger for more surfactants, more PCO2 clearance. So could that be also an element in the precursors to the pulmonary hemorrhage that we should investigate in the future? So it is driven by vascular immaturity. We know that there's an element of fragile capillaries that are prone to rupture, similarly to what's happening at the brain level. So it might be either associate that they have this IVH or not necessarily causal, but just happening at both at the same time because similar pathogenesis. We know that contributing factors may include also positive pressure ventilation, exposure to oxygen, but we'll talk a bit more about the aspect of LV stiffness, knowing that prematurity is one of the common risk factors in these patients. So RDS on its own involves inflammatory changes in alveolar edema. This can lead to a lot of inflammation and increasing this vulnerability to the capillaries to break. And so if you do have some of these sudden hemodynamic shifts in PVR and SVR, and especially if you're giving surfactant in a way that you'll have maldistribution, you may create zones of low PVR and zones of high PVR within your lungs. And this may also be something that could potentially increase the risk of having capillary breakage. We also know from animal models that high-dose surfactant have a possible impact on coagulation, prolonging the clotting time. So that is definitely something to keep in mind when we're looking at the multifactorial effects of surfactant and its association with pulmonary hemorrhage. We also know that in RDS, if you expose these patients with high airway pressure, you end up with alveolar overdistension, which can lead to trauma of both the parenchyma, but also these little vessels that are within these alveoli that can rupture. And so we know that pneumothorax remains one strong risk factor, and that could be through, in part, this mechanism. Also, these patients tend to be exposed to a lot of oxygen, and there's a component of oxygen toxicity as well as oxygen being a pulmonary vasodilator. So in RDS, you may have a lot of areas of atelectasis. And so if you're preferentially exposing some of your pulmonary vasculature to oxygen, you may both increase the inflammation to this area that are oxygenated, as well as increase the pulmonary blood flow to these areas, which may also lead to some of the degree of increased bleeding risk and capillary permeability within these areas. So again, a beautiful picture by Dr. Satyan, which is within the review, which actually tracks down this effect of hemorrhagic pulmonary edema and RDS, and how to use some of these modalities to improve and tamponade during management. The PDA, I think we're going to have great discussion during the panel discussion, but we know that, physiologically, if you have an unrestricted left to right shunt, increasing QPQS and pulmonary blood flow, this may be a problem to overwhelm the pulmonary vasculature. But I think this is particularly true if you have a left ventricle that's non-compliant And because of that, your LA starts having issue draining into the left ventricle. And because you get a lot of pulmonary blood flow coming to your left atrium, you may have increase in your LA pressure that may have difficulty decompressing somewhere. And so that may also be an element that adds on to the physiology, because we see many patients with PDAs that are left to right and they don't develop pulmonary hemorrhage. In our center, we have kind of a very conservative approach to the PD management, and we don't see that many of pulmonary hemorrhages. So it's something to keep in mind in your center. If you do have a lot of pulmonary hemorrhages, what are these other factors that may also contribute to that? There are, as we know, conflicted data from the trials. I'm not going to go into the details of the challenges of some of these trials and defining what's a hemodynamically significant duct. But what we see is that in some of the earlier trials, like the TIP trial, and the one from Dr. Klukow from Australia, there was a signal in terms of the early onset pulmonary hemorrhages in terms of dropping significantly the rate of that. But when you looked at the more recent trial or throughout the hospitalization of patient, we seem to lose a bit that effect. I think that part of the reason might be that NSAIDs are pulmonary vasoconstrictors. And so it may mean that these patients may have some degree of pulmonary vasoconstriction related to the NSAIDs administration. But as well, NSAIDs might have a theoretical action on platelets, and it may also have an action on SVR and acute kidney injury, as well as coronary perfusion. And so these things may also impact the overall incidence of pulmonary hemorrhage effect from NSAIDs. And so with new studies looking at more strategies of combining some of these medications, or using shunt mitigation with approaches with Tylenol or with cath closure, we may see some differential responses. So my dreadful concern would be this picture, which is having a large left to right duct and a really compromised LV function, where you see a big LA that has this quite restrictive interatrial shunt that looks like it's almost popping off a high pressure LA. So in this particular phenotype, I think that the priority would be to rescue this left ventricular function. So this brings me to the idea that we know small for gestational age, we know IUGR is a risk factor, and we know babies with IUGR have increased risk of placental dysfunction. They have increased vascular stiffness, and this is both in their own systemic vasculature and the placental vasculature. They may also, because of that, diminish during fetal life the right to left shunting at the PDA level, which forces blood flow in the pulmonary vasculature and may remodel the pulmonary vasculature. So some babies with IUGR may be at risk of acute pulmonary hypertension after birth. But all in all, there's a lot of data showing that these IUGR babies are actually more at risk of having some disturbed compliance of their left ventricle, which may be a component explaining why they're more at risk of developing these pulmonary hemorrhages by having this post-capillary congestion type of picture. Sepsis is definitely involved in the pathogenesis. There's many reasons why. The coagulopathy, the DIC, NEC could also trigger this in a long-term, more than around 2-week period of time. And when you combine sepsis with coagulopathy, DIC, cardiac dysfunction, capillary leak, these patients are at high risk of developing pulmonary hemorrhages. And that's often a common mechanism we find in some of these low-resource settings. We spoke about growth restriction. I just want to mention that babies who are growth restricted may also have an impact antenatally on liver hypoxia, which we know can impact both the coagulation profile and thrombocytopenia as well as platelets function. So these patients, on top of having some degree of cardiac remodeling and vascular dysregulation, could be at risk from a hematological standpoint from developing pulmonary hemorrhages. I'll skip this. This is a great figure that's outlining all these mechanisms of shear stress, PDA, fragile capillaries, growth restriction, and LV dysfunction. It's in the review, and I'll let everyone go back to that when they have time. So what are, in the last 5 minutes, ways to improve our outcomes of our babies? So we know that some of the protective factors are antenatal steroids, avoiding hypocapnia, making sure that these patients have transitions that is as smooth as possible. So potentially delayed cord clamping may be also a protective mechanism, but it's not been studied yet for specifically pulmonary hemorrhage, from what I know.
And of course, avoiding some of these agents that may precipitate acute changes, especially they're unnecessary. So for example, giving like medications that are cardiovascular agents in a patient that is otherwise well just to treat numbers is probably not something that is recommended nowadays from the body of literature that we've mounted in some of these patients. And there is more studies coming up, especially from the group of Dr. Mitra about prophylactic endo, especially a one dose that's going to be studied in an RCT. We know that the TIP trial showed us some improvement of severe pulmonary hemorrhage in the first week of life, but not overall. So we'll see if this could be a benefit of the study by Dr. Mitra. Of course, if you have LV dysfunction, the idea would be to recognize these phenotypes, treat them appropriately, avoiding INO in patients without pulmonary hypertension, optimizing surfactant distribution to avoid heterogeneous effect on PVR. And of course, I'm a true believer that diligent care in these babies, the devil is in the details. So for example, your oxygen titration to avoid unnecessary oxygen exposure could also be part of the equation, as well as treatment of underlying infection and sepsis. So I've put here some of the more common, cardiovascular phenotypes that we see, especially once pulmonary hemorrhages has occurred. So acute pulmonary hypertension definitely can occur like our first case scenario. So in these patients, of course, you want to, address this phenotype. Ideally, you don't want to have excessive mean airway pressure in these patients because it can compromise venous return to the left atrium, as well as increase RV afterload and participate to this RV dysfunction. So in some of these patients, if they remain hypoxic, once you have, appropriately managed the respiratory standpoint, you may still need to consider pulmonary vasodilators to support their rescue. And again, this is not supported by RCT, but by anecdotal and observational evidence. LV dysfunction, of course, if you have significant hypoxia-induced myocardial dysfunction and impaired contractility, as well as disturbed coronary perfusion, these are patients you want to address by being very careful when you're starting to administer fluid. So you don't want to flood these patients necessarily, especially if you have to replace some of these blood products. And you may also want to, provide some inotropic support in some of these patients. Loss of preload is something that can become a problem if there's an acute bleed. So these are patients you want to be very careful on how you're going to titrate the different blood products you're going to be providing to rescue their phenotype, and especially if they look underfilled. This may contribute also to some of your PVR-SVR relationship, especially if you're very vasoconstricted because your system is underfilled. And then finally, you do want to characterize your shunt physiology to better understand what could be a contributor, as well as how you could potentially use this information to better treat your patients. So in general, from a respiratory standpoint, we want to optimize oxygenation, minimize additional pulmonary injury, correct the hemodynamic instability, and manage the coagulopathy. Typically, we do gentle suctioning. We avoid removing all the blood clots or aggressive suctioning, which can entertain this pulmonary hemorrhage. And in our center, we typically favor oscillation. It's not based from RCT, but it's based from the physiology that you get better transmission of mean airway pressure to your distal alveoli. But again, a message, beware of excessive MAP, because at some point you will be detrimental to your patient. And in some patients, you can also consider JET or even conventional mechanical ventilation if you have good results in your population with that. But in these particular ventilation mode, it's more about the PEEP optimization than the MAP, because PEEP drives more of your MAP. Comfort measures are still important, both pharmacological and non-pharmacological, especially to decrease the oxygen demand if you have cardiac dysfunction. Anecdotally, there's evidence that if you have an acute uncontrollable bleed, you can consider intratracheal vasoconstrictors. The most common one is intratracheal epinephrine, which is administered via a thin catheter that is going inside the ET tube and not above, like where all the blood and the clots are. So you have to be careful about the way of administrating it. Sometimes you even have to dilute it in order to have a better distribution of the medication. But the issues with these drugs is obviously the side effects. So you can get a transient, very acute increase in PVR or SVR. You can get tachycardia. You can get airway or vocal cord ischemia, depending on where you're given, tissue necrosis, arrhythmias. And so there's non-benign effect of giving these kind of therapies. And surfactant is often described to be given because you get surfactant inactivation once the bleed is controlled in order to re-administer surfactant after the active bleeding. Blood products and coagulation factors are definitely dependent on the profile of your patient, and there's been case reports of all of these things that are in the review, so I'm not going to go there today. I've put here the table in the review that has kind of a more detailed interpretation of these management strategies. And now for my conclusion, basically pulmonary hemorrhage remains a life-threatening complication in preterm neonates. It's a multifactorial, very complex pathogenesis, which can involve some or all of these elements, such as vascular immaturity, hemodynamic stress, inflammation, coagulopathy, ventilation strategies, genetic predisposition, antenatal factors, etc. I do think what's very important is to recognize that these patients can have different phenotypes. And so TN-ECHO may help you with your comprehensive assessment of this dynamic cardiovascular changes to guide your therapy and enable real-time monitoring so that you're able to titrate and wean some of these supports that come also with side effects. So you use TN-ECHO to better define how your patient is in terms of pre-pulmonary hemorrhage in order to prevent some of these pulmonary hemorrhages, also during the acute bleed and once the bleed has subsided. But I still think that ongoing research, such as RCTs that are coming from Dr. Mitra's team, will help us better refine some of these risk stratification and personalize the care of these patients. So thank you so much. I hope I was able to address some of the objectives of your today's pulmonary hemorrhage topic. And I'm really looking forward for the discussion by the panelists. And I'll be very happy to take any questions, comments, or insults.
Thank you, Dr. Altit. Hopefully not the latter. That was a wonderful talk. And I'd highly encourage our audience to reference that paper that you linked. It was really excellent. It covers a lot of the concepts you talked about today and was just published, it looks like, this July. So congratulations for that too. So to start, I'm going to introduce our excellent panel, and then I'll let Dr. McNamara take the first question. But for our panelists, we've got a great group today. So I'll start with Dr. Hébert, who's an assistant professor of pediatrics and neonatology at Laval University, where she's a staff neonatologist and the hemodynamics program director at CHU in Quebec. And she leads clinical and research initiatives focusing on advancing neonatal cardiovascular care and improving outcomes with critically ill neonates. Next, we have Dr. Mitra, who's also an associate professor of pediatrics at University of British Columbia, staff neonatologist and research director in the Division of Neonatology, and NHT&E program co-director at BC Women's Hospital. His research interests are including improving outcomes of interest with PDA. And finally, Dr. Makoni, associate professor of pediatrics at Oklahoma Children's Hospital and the University of Oklahoma Health. She is the director of neonatal hemodynamics clinical and research programs at that hospital, and her research interests include integrating neonatal hemodynamics into clinical care, promoting individualized physiology-based care, and pathophysiology of pulmonary vascular disease. Really happy to have you all with us. And Dr. McNamara, if you'd like the first question.
Thanks, Rachael. So Gabriel, that was phenomenal. As always, as expected. I think you provide a very comprehensive and thoughtful overview of the field. I want to go back to one of the cases that you presented. I think it was the first case. And I want to get to the heart of one kind of issue because you talked a lot about the multifactorial etiology behind pulmonary hemorrhage. And for most people who have taken care of a baby with a real pulmonary hemorrhage, it's a very scary thing, and the babies are profoundly ill. The question I want to get to is nitric oxide, okay? Using nitric oxide as an empiric therapy without knowing the underlying cardiovascular phenotypes. You talked about LV dysfunction as a potential contributor. You've also talked about, large left to right shunts as a contributor. Obviously, it's going to drop your PVR and drive a big left to right shunt. Do we need to be more thoughtful about nitric oxide and what should be the starting dose? Because most people will go to a dose of 20. Is that the right thing to do in acute pulmonary hemorrhage? So again, a complicated question, and there's probably not a science, but I'd love to hear your thoughts on it.
I think I'll start, but I know our panel probably will be able to complement a lot. I think Dr. Mitra, for example, gave a whole talk on this at NeoHeart. But for me, I'm always very suspicious about starting INO without getting more physiological information. I think it's because for me, it's so easy. I can just grab the probe and get the information at bedside and better understand what's actually happening with my patient. And I've seen different phenotypes with some of these patients that come in with like the picture of RDS. And the first thing I'm always concerned, well, this RDS, are there areas that are very atelecticized? And then there's these like 3 alveoli that are open, and I'm actually giving INO to these 3 alveoli and they're all going to burst because all the rest is vasoconstricted. So I'm all going to concentrate this torrential flow to these 3 alveoli. So that's always a big concern of mine. Number 2, I'm always concerned, could there be an underlying LV dysfunction in some of these patients? Because we've seen many of these patients with some degree of asphyxia, some degree of sepsis, choreo, infections, TTTS. There's so many other reasons they may have like various phenotypes that contribute to LV impairment. And some of that right to left shunt at the PDA, and these patients are actually necessary to maintain because you need that flow to support your systemic vasculature. So that's a kid I don't want to give INO. I want to keep like low oxygen. I want to keep my high PCO2 because I want to vasoconstrict my PVR. So that's like another phenotype in which we do need to be careful before just giving, blindly INO in some of these patients. Some of these kids may just don't even have a PDA. The PDA has become like super small. So you assume there's no acute pH and then they're blue and you're like, it's just the lungs. And then you just increase your MAP for some reason. And then you end up coming in, you do a TNE or an echo and you see that there's actually barely any pulmonary blood flow and your RV is failing. So that's a kid I would want to potentially start INO depending on my ventilatory status. And then we've seen some patients with what we call functional pulmonary valve stenosis, which they have such bad RV that actually your PDA feeds your pulmonary vasculature. And in these patients, you want to maintain that PDA open, you want to maintain that pulmonary blood flow via the systemic tract. So I'm just naming so many physiologies that can happen, and that without getting more of that information, if you just blindly start INO, it's, you confound all of this and maybe you actually hurt some of these babies. Mm-hmm. And then there's the last category, which is like this true acute pulmonary hypertension in which you maximize your ventilatory support and your recruitment, and you still have high PVR because they've been ruptured since 16 weeks. And, they do response to INO. In our protocol, we start at lower doses. That's just because of experience. At 10 ppm, we see a huge response. So we start with 10, but that's been our local practice. So I'm very curious to hear what other speakers have in mind regarding that.
Yeah, go ahead, Dr. Mitra.
Yeah, no, thanks, Gabriel. In addition to what you just said, and I agree with all of that, a couple of other things to keep in mind is one, INO may affect platelet function, and when the baby is bleeding, that is already compromised. You just mentioned the association with IVH, and nitric may worsen IVH in the smallest babies. There is some evidence from trial data on that. So it is a scary drug in this situation. And therefore, I'll be very careful. And as you rightly mentioned, that identifying, teasing out the physiology is so important here compared to some of the other babies. If you have an LV dysfunction, then obviously giving nitric will cause more problems. It is taking away the blood from the systemic circulation and causing compromise of systemic circulation. The problem that happens sometimes is that you have this duct that probably induced the hemorrhage, but then we sat on it, and now the baby is in hypoxic respiratory failure, and now you have a right to left shunt, and you start nitric, and then you have a response and you walk away, and then you come back 12 hours later and the baby is worse. So that's where, coming back to Patrick's point, what we would do is, one, we would start at 5 parts per million. Like in our CPS statement, we had mentioned between 5 and 10. Second, as we always tell our trainees, do not leave the bedside if you choose to start nitric. based on the physiology, you have established or a well-supported LV or a normally functioning LV, and you have established an elevated PVR physiology, and the baby is seriously hypoxic, you have no other option, you've given all your supportive management, all that you nicely described, you're still hypoxic, you start nitric at 5, and you sit there, watch for the response. If there is, as there is clinical and echocardiographic, proactively wean it down, much more proactively compared to some of the other babies, like term babies, where you would follow like a nicely developed protocol. So that's what we would do if we choose to use nitric, but that is not our go-to in the first place.
Thanks, guys. Anybody else, either Marjorie or Audrey, any other additional comments you want to make on that? It is an important issue because when these babies are satting 75, 80% and 100% oxygen, this is what people think is the standard of care clinically for presumed pulmonary arterial hypertension. And I think it's important to actually think more deeply about this. I think that's the comment from the group here.
And thank you. I think it's such an interesting question and I think there's a big difference though between there's like two discussion here, right? It's the pre-pulmonary hemorrhage and then the post-pulmonary hemorrhage management, right? Because your physiology changes so much and your phenotype changes so much when you have a baby who is about to do his pulmonary hemorrhage, and then after that you have to manage. And I find that the patient that we put the most on nitric oxide is actually post-pulmonary hemorrhage, right? And it's such a scary thing to do because you have this patient that is bleeding, and you're going to start a vasodilator, and it's always scary to make things worse, but these patients often respond just because their physiology changes, their PVI increases. And I agree that phenotypes is so important. If you're having LV dysfunction, you don't want to start your nitric oxide. However, and it's easy for us to say because we can do easily at bedside an echo and find the phenotypes, but sometimes when it's 2 a.m. in the morning, you don't have access to an echo. You don't do an echo yourself because you don't know how, and that's fine too. Sometimes you sort of have to go with physiology at bedside without the echo. And I agree with Souvik that if you're going to choose to start nitric oxide to manage your pulmonary hemorrhage, it's just important that you stay there. And if things improve, then great. But if things do not improve or worsen, then you need to be able to stop your drug, which is the nitric oxide in this case, and make sure that you reevaluate what you're doing and maybe that you got the underlying physiology wrong, which is a difficult thing to do without an echo, but I think it's reality for a lot of people that are probably on this call. So, but getting an echo quickly as soon as possible is also important just to make sure that we have the right phenotype.
Thank you, everybody. Everything is very true that you have all said. What I find particularly challenging is when you walk in the morning, a baby has had pulmonary hemorrhage, and they were given intratracheal epinephrine. Those are the ones that are particularly challenging because I have found that now you have this waxing and waning pulmonary vascular resistance, and you have to play that game where you're on INO. You usually start at 5, then you titrate to effect, you stand there, you come back in an hour, outside the room, you go back in, you scan, and now you have hemodynamically significant PDA, you stop wean your INO down, and then you end up having this waxing and waning physiology. So for me, that's one where I find it particularly challenging. Like, what's the right thing to do? Where's the middle ground? And obviously, when you don't have that capability to do an echo, it becomes very challenging. That's where you might end up seeing a recurrent pulmonary hemorrhage because initially, maybe yes, you needed to put the baby on pulmonary vasodilator, INO, and then when the physiology changes, sometimes there's no readily available bedside clinical parameter that you can see to let you know that it's time to come off. So very interesting question without one straight answer.
I think the message I'm hearing from all of you, though, is very frequent reassessment, right? Because physiology changes, as we know. So maybe in that vein, going into what Dr. Hébert was starting to refer to, and that we've got a post-physiology and physiologies, but what about that like before pulmonary hemorrhage happens? And Gabriel, you outlined really nicely like risk factors and things that you're thinking about, things that babies are higher risk. But what are you all doing in your centers when you identify those high-risk babies, or how do you identify them? What do your screening programs or practices look like? I think one of our attendees was asking about, like, are you rescreening for a PDA before you give surfactant, for instance? Are you comfortable like extubating like early preemies? Like, what are the risk things that make you worried, and what are your practices to protect? Maybe starting with you, Dr. Hébert, and then we can kind of work around the panel.
Okay, that's a huge question. So we, and this is why we actually did, and thank you, Gabriel, for highlighting our study, but I think that's why we did that study in our center, kind of going back to our cases and trying to identify how we could identify these cases and help prevent. And I think we know risk factors, we know the IUGR babies, we know not giving surfactant. Sorry, I'm on call, so sorry. It's not about not giving surfactant. I think surfactant, we know in neonatology, is so important, and it changes. I mean, it has changed the world of neonatology. So I'm not saying don't give surfactant, and we don't always have the ability again to do an echo prior to giving surfactant. We usually give it one dose without any problem. However, when we are about to give a second or even third doses of surfactant, sometimes it is something we'll consider. Is there a huge PDA? Like, are we going to decrease PVR too fast? I think these patients, what we know is you don't want to do anything too quickly. Sort of doing everything very nicely and slowly, lowering your PCO2 nicely and slowly. So we don't have, it's a lot of words saying we don't have one thing that we do. We don't do a screening like you guys do. I know in Iowa, I know you've have amazing numbers, less than 1% pulmonary hemorrhage in that paper from Reagan. You can probably speak more to it than I can. And I think screening, your screening protocol in Iowa, I think you do in the first 12 hours or up to 24 hours, obviously seems to be giving amazing results. We don't have the manpower to do that at our center, so we don't do that sort of screening. We do it more based on symptoms. However, sometimes when the symptoms happen, it's too late. So unfortunately, that's something that I think your center seems to be doing great, and it would be really great to hear more about it. But at our center right now, I mean, we do try to assess sometimes before giving more than one surfactant, but it's not something that we do systematically. And then I'm going to stop talking after. But one other thing that we found in our study is that the cases had lower blood pressure, like up to 8 hours before the pulmonary hemorrhage happened. There was really a significant trend between not only diastolic, which would make sense with the PDA, but even systolic blood pressure was significantly lower in the cases compared to the control. So it's something that we try also to be sort of more maybe in terms of aggressive, in terms of if we see the blood pressure kind of coming down after 24 hours, and it's something that we need to like be a bit more something that we need to look for a little bit more closely. So, but interesting to see what they do in other centers.
Marjorie, Souvik, Gabriel, anyone else want to jump in?
So here in Oklahoma, we have actually to help with the screening, since there's only a very few hemodynamic specialists out here. We have engaged cardiology, and they do all of our screenings for our elbows. We call them elbows, the micropremies, in the first 18 to 36 hours. And their echoes are able to give us the information that we need. So, and it's very specific. It's read by specific people. Only 5 cardiologists who read those echoes. So it has been really helpful to have that information. But sometimes, you know, I think the timing of when the surfactant second dose was given is always, And the people here know I always say, if you have to give second dose of surfactant and you're past that 24-hour mark, then that is a baby that you absolutely want to screen first. And you can get either a cardiology echo or a hemodynamics echo. And I do find that the ones that usually happen overnight, when you've tried everything and you don't have that availability to get somebody in to come and evaluate for your PDA-LV function, those are the babies that most of the time get the pulmonary hemorrhages. But it's not a lot of them. We try to have a higher FiO2 threshold, and we try to have really tighter blood pressure goals around that 24 to 36 hour period in order to help reduce that. And since we started doing this has been about 3 years ago, that we've had an improvement in the level of pulmonary hemorrhage that we see in our unit.
I agree with Marjorie. Our practice is very similar to yours. Obviously, there was a logistic challenge to begin with, trying to get early echoes, but the Smart PDA results were compelling, where we had a significant reduction in pulmonary hemorrhage in the early screening and treatment group. And that kind of helped us to institute the protocol locally in our clinical practice after the trial was done. So now every baby born less than 26 weeks would get a screening echo, ideally within 24, definitely within 48, depending on resources. And as you said, that for us, it's difficult to get an echo prior to the first surfactant, but almost always they get an echo prior to consideration of the second surfactant. And if we find like a big left-right shunt or associated LV dysfunction, then obviously those would be factors that will be strongly considered and deterrent to giving a second dose of surfactant. We're looking at post the trial, we're looking at a longer period of time to see the rates of pulmonary hemorrhage, but anecdotally, we find that the rates are a lot lower because we hopefully would have prevented a massive pulmonary hemorrhage in some of those babies with a clearly shunt-mediated physiology.
Yeah, if I can add, locally, I think everyone has like their team-based approach, and that's what's super important. Is to look at like locally what are the strengths in your team, how to build everyone together around a topic. And of course, if your unit you don't have pulmonary hemorrhages, you want to maintain whatever you're doing to prevent them from suddenly appearing. But if you have a lot, then you really need to go and deconstruct what are all of these different aspects in the care that could be contributive. If part of it might be prenatally, like how do you sensitize to improve antenatal steroids administration, all these things. So locally, we're fortunate in our unit that our rate is very low. I actually had to dig a lot to find these two cases. It's not about bragging. It's just like, thankfully, it's not that. And I think part of the reason we don't see that much pulmonary hemorrhages is that we're quite conservative in the first few hours in terms of how we're going to be administering surfactant in some of these babies. So we have a huge, a non-invasive respiratory support approach in those babies that are a bit more mature. Like we're talking about these babies more like, 26, 27, 28 weeks. We try to maximize their CPAP, bubble CPAP approach. And of course, their transition might be less acute than just being intubated, getting surfactant. I think it's quite different, and we know from the literature in those micro preemie babies, like the 22 to 24 weeks, and you can even go to the 25 weeks, where their ventilatory status often require that they go into mechanical ventilation and they do get surfactant, and that's true at least in our unit. And so in these patients, we're a bit more careful. These are the patients we don't have a systematic screening, but I would say that our protocol says if you're considering any kind of cardiovascular agent in these patients, then we would need to get at least a TNE or an echo before we initiate some of these agents. Of course, at night, it becomes a bit more of a challenge, but then we're being triggered very early on for these patients. In any case, if INO is envisioned in some of these babies, we also try to see them as early as possible, ideally even within the initiation period or before the initiation of INO. And we try to be very careful about initiating medications for just numbers. We actually try to get more information about the physiology before doing that. And then we're also very careful about excessive oxygen exposure or CO2 clearance. So in these patients, like the very tiny ones, we have an approach where if they get intubated, they often will be managed on jet ventilator. And if those who are not used to the jet, you can CO2 clear very, very quickly in some of these babies. So you have to be quite gentle, and the amount of mean airway pressure should be also limited. Like you don't want to overdistend these babies. So these are babies that were actually happy when they're a bit underinflated, because then if not, you're just destroying these lungs and you're probably flushing too much CO2 and then decreasing too much their PVR and just increasing the shunt volume. So these are kind of the strategies we have put in place. But again, I think in any of these units around the world that are listening to us, if catastrophic pulmonary hemorrhages is something you tend to see very recurring, I highly encourage you put together a team, QI, and then go see some of the units that are having good results. Example, like Iowa, who has, almost non-existent pulmonary hemorrhages, and then see what are those things that you could be looking in some of these risk factors, either antenatally or immediate at birth or postnatally, to improve. Some of which could be your admission temperature. Your baby are coming all hypothermic. If that's the problem you need to address, you need to put kind of a QI bundle around that. So I would think that's kind of the approach, I would recommend.
Audrey, can I ask you, a little question around kind of lung ultrasound, okay? And the role of lung ultrasound, and should it be part of our routine early echoes? And the reason I ask is I hear in different centers people say we see a lot of post-extubation pulmonary hemorrhage, and obviously that's kind of not a good thing to have. Like I actually had not seen, Gabriel, the data on mortality for pulmonary hemorrhage. That's really scary. Kind of, and this clearly preventing pulmonary hemorrhage is an important thing for us to be able to do. But kind of, is there a role for lung ultrasound in this? Can it help us identify populations of risk? I know it's a hard question, but
it's a really hard question because I don't do a lung ultrasound, so it's a hard question for me to answer. Most likely, I think Gabriel showed some data, so probably he can answer a little bit more this question. But I just want to kind of add to your part of seeing post-extubation pulmonary hemorrhage. We actually, so it's not about lung ultrasound, but we choose not to extubate our patient in the first 72 hours for our extreme premature patients. So I'm not talking like the older patients. We actually now use MIST and ERLISA in the older populations, but in our very extreme premature, if they do get intubated for RDS or in the delivery room, we actually don't extubate in the first 72 hours just to try to avoid that post-extubation pulmonary hemorrhage, which is even worse because then your baby is not even intubated. You're trying to manage a baby who's having this catastrophic event. So but on the lung ultrasound, like I think the lung ultrasound movement is gaining a lot of momentum, and I think there's very interesting data coming out. I was actually interesting to see that part of the presentation from Gabriel, but it's not something that we use right now. But probably could get on the wagon of the lung ultrasound a little bit more. Yeah.
I was wondering, could I follow up on the question of like in Dr. Hébert, your study, you had the atrial communication, the PFO, was larger, I think, in the cases of pulmonary hemorrhage, which was kind of surprising to me because something I kind of thought about would be thinking that like a larger atrial communication might be somewhat protective in those patients. Could any of you kind of comment on that? Or is that something that anyone else is thinking about too? Or is that kind of a Iowa-ism?
Maybe I can give my, because we had a bit of discussion, me and Audrey, about this, and hopefully, Dr. Hébert has seen all of these echoes, so she probably has this extra level of knowledge of seeing all these echoes one after the other. But one of the, I kept on going back and forth, and I said, well, is this the reflection of, you could still have poor LV compliance and high LE pressure. This LE becomes bigger, and you kind of stretch that PFO, because I saw the average, it was like 2.5 millimeters. It's still a smallish PFO, I would find, so I wondered if some of these cases were actually these kids who have some degree of LV stiffness because they're IUGR, because they're like asphyxiated for some of them with like, antenatal factors that are related to their degree of conditions. And then because they start getting a lot of this QPQS, you start getting this LA stretch, and maybe it stretches that PFO. That was kind of my only way of explaining, but we might learn from other groups. So I'd love to hear what Dr. Hébert thinks about that.
Yeah, so yeah, it was interesting data. It was actually the opposite of what we thought we would find, which is always the interesting part about doing research. And I did all the measurements by myself, so I did see all the echoes. So it's done by one person, and this is not published yet. We're working on the manuscript yet, so hopefully it gets published. But I do think that I think I completely agree with what you just said, Gabriel. The echo was done, so this is retrospective. So right, the echoes were done sort of the 24 hours prior to pulmonary hemorrhage. I think there's probably a shift in the physiology that happens really quickly in these patients, that they probably have high PVR, they drop their PVR, and probably there's more blood coming left to right from the PDA, because these patients all had a PDA, and probably coming back from coming back to the left heart. If you have sort of the LV dysfunction, a lot of these patients, like Gabriel said, were IUGR, might have a degree of LV dysfunction, and then you just have a lot of blood flow coming back to the left heart, sort of stretch PVO, and then boom, the pulmonary hemorrhage happens. Honestly, I was surprised to see this. I measured them more than once just to make sure that I was not making this up. But I really think it's just because of the timing, and this is not prospective. So, I mean, there's limitations being retrospective, but I really do think that there's a change in physiology that happens, and that the PVR drops, there's more blood flow coming back to the left heart, which is probably have some sort of LV dysfunction, and then stretch PFO, and that's when probably the pulmonary hemorrhage happens. But happy to hear other thoughts, and I can include that in my discussion because I think this is a big part of that paper. But yeah.
Yeah, it made me wonder if like on all of these early TNEs, we should almost get like clear. I don't know if you do it in your protocol in Quebec or Iowa, like a Doppler, like each time a pulse wave Doppler at the level of the PFO itself, and like just to get a sense of the velocities. Because although we don't get clear RA pressure measurements, if you have like a big gradient, like a mean gradient above like 3 or 4 or 5, so early on, maybe that could be, at least to get the information as we go forward in some of these rare cases. That was one of my thought of, that could be interesting to at least get a sense of the relationship between the LA and the RA. But love to hear from other thoughts.
So Gabriel, I was kind of curious, like, was there an association between like LA volume, was that measured? Because if the LA is stretched, then does it matter how big that little PFO is? And are we splitting hairs here? There's already so much of volume. It's because of overflow plus LV dysfunction, then that's essentially causing the backup and the hemorrhage.
Yeah, it's hard to tell. Like, I think there's so many factors we don't understand yet. Like, I think another element would be how much of, prolonged atrial regurg you get in your pulmonary veins, for example, as a marker of high LA pressure. Yes, your PFO could be stretched, but you could still have some degree of restricted flow through it. So it doesn't mean that it's going to completely, decompress the LA. And sometimes you may be fooled. The LA volume can change from beat to beat. So you may have one beat that drained correctly, and then the next beat you have like a bigger LA because it was not able to like decompress in the LV. The other thought I had was, could the amount of LA to RA flow, just the QPQS, increase from the interatrial shunt on top of the PDA, also to some degree contribute to the excessive flow going to the lungs in these early periods? So I think there's like so much to kind of deconstruct. I think what's exciting is that, we'll need to work together as like, international teams to kind of better understand the physiology, just because every center has like so little amount of cases. But I think as teams are going to incorporate diligent screening programs in their unit, we'll get more and more of this information. And so we'll be able to take these rare cases everywhere. I think the big rate limiting issue is that many centers don't have screening programs. Like, for example, we don't have a systematic screening programs. I'll be fully honest. I think part of it is manpower. But as many centers will emulate these assessment programs in the early phase of transition, we may get more information. Like, for example, Dr. Makoni, who mentioned that she started integrating that. I know Iowa, you have a program, Dr. Mitra. So maybe we'll be able in a few years to put these few cases in all of these centers and better understand what they look like before the actual event from a hemodynamic perspective. Because all the cases I presented, I looked and I only had a TNE like in the immediate moments after the actual event. And so I couldn't take any conclusion from the pre-echo. I don't know, Dr. Hébert, if you have many of these echoes done like preemptively before the event, or if most of them were after the event, but that would also give us a lot more information on the like pre-event physiology.
They were all pre-event for us in order to be included.
It's a tough question where I think we're struggling with the lack of ability to kind of have equivalence of shunt significance versus atrial level shunt size. If I think that's the problem. They're so interrelated, and trying to tease it out becomes very, very difficult. And I think it's a very complex conundrum to get to the bottom of it. But Audrey's data certainly is very, very helpful. So, Rachael, do you want to wrap it up? I think our time is at the end.
We're done. We don't know. There's a lot of questions. Are we out of time?
Yeah. For those people that we will try to get to the questions, and then kind of Laura will send it, and kind of we can try to answer them.
Okay. No, thank you. I mean, this was truly an excellent discussion. So really appreciate all of our panelists, our excellent speaker, Dr. Altit, and all for joining. As Patrick said, then we'll add some of these questions so Laura can get these back to the people that asked. Thank you all so much for participating, and we look forward to the next session, which Laura or Patrick, do you actually have the date or information on the next session? So
2 months for now, and I'm blanking what it is. It's pulmonary hypertension, acute pulmonary hypertension. I think it's in preterm babies. I think that's what it is.
That sounds great.
Yes, it is.
Looking forward to that session then. Thank you, everyone.